Good afternoon, everybody. I'd like to welcome all of you to our next session for the APDR National Virtual Noon Conference Series. My name is Dr. Hart Beatty. I'm the chair of the APDR Education Committee and the Neuroradiology Fellowship Director at Boston Medical Center. It's a great pleasure to have you with us again today. We have, once again, two great speakers in this amazing lineup, and we'll be on to their chest imaging talks in just a moment, just to go through a couple of brief housekeeping items with you. As you all know, the talks will be recorded and they'll be hosted on the APDR YouTube channel within a few days' time for turnaround. The questions and comments are also being recorded. In addition, as you attend or join onto the webinar, your microphones are muted to ensure optimal quality for the participants. And if you do have questions for the speakers, we ask that you use the Q&A platform in Zoom to ask those questions, and we can try to either answer them live if there's time at the end, or our speakers will email you if they have the time in the next few days to do that. So I'd like to introduce our two educators for today, Dr. Jonathan Chung, a professor of radiology and section chief of thoracic radiology at the University of Chicago. It's a great pleasure to have him. And also Dr. Darel Heitkamp, thoracic radiology for AdventHealth Medical Group. He's a prolific educator, and we are so fortunate to have both these guys with us. And, you know, like every speaker we've had, they're also just great human beings. So really happy to have both of you. Without further ado, I'll stop sharing my screen and I'll invite Dr. Chung to share his screen, and we can get started.
Well, Harp, thanks so much for the kind introduction. Really appreciate it. And really a great pleasure for me to be here. I'm going to be talking about diffuse nodular lung disease. So got a lot to cover, so I say we jump right into it here. So if after this talk, you are better able to recognize the different patterns of diffuse nodular lung disease, and then based on those patterns, formulate appropriate differential diagnosis, and then recall imaging or clinical findings which allow for a more specific diagnosis, which within these sub-patterns, I feel like I would have been successful. So let's talk about where we're going first. We're going to talk about what we really mean by diffuse nodular lung disease. Then we're going to talk about those subcategories. And the subcategories are labeled random, centrilobular, and perilymphatic. A lot of you probably have heard these, so I think this would be a nice summary for or review for a lot of you, but maybe this is new for some of the more junior people who are on this. And then we'll just wrap things up. So first of all, what are we not covering? We are not going to be talking about indeterminate pulmonary nodules, thankfully. So no solid or ground glass nodules, no discussion about that, no discussion of Fleischner. We're not talking about few scattered subcentimeter pulmonary nodules either. Really, that's covered by Fleischner or lung rads, depending on the setting you're in. And unfortunately, we don't have time to really talk about AI or CAD, though I think it would be interesting to talk about that. But certainly, we only have the 25 minutes. So what do we mean by diffuse nodular lung disease? We're talking so many nodules that you can't count them, right? And so someone who, if I'm giving this lecture live, will always say, well, you can always count them, right? And so really it's the how many is innumerable, right? And to me, if you start counting anything greater than 20 nodules, it's innumerable, right? No one's going to spend their time counting that many nodules. And so if you have that many nodules, you're probably dealing with a diffuse nodular lung disease. Usually these nodules are smaller than 4 to 5 millimeters, almost always bilateral, and generally symmetric, though you can get a little bit more patchiness in the perilymphatic and centrilobular pattern. Before I give you examples of these categories of diffuse nodular lung disease, we should talk about MIPS. So these are maximum intensity projection images. So I'll tell you, when I was a resident, even a fellow, this was not standard of care. There were a lot of places that did it, but a lot of places didn't. But I think nowadays, in 2020, this really is standard of care. So if your center is not routinely reconstructing maximum intensity projection images, you probably should. Certainly, these increase the conspicuity of pulmonary nodules and can sometimes improve your diagnostic skills in regards to vascular abnormalities as well. And so you could do them variable thickness with variable overlap, you know, so 10-5, right, 5-1, like it doesn't really matter, but you should be consistent and it should be something that's agreed upon at your local institution. I personally like 10-5, so 10 millimeter thick with 5 millimeter overlap. And that way there aren't that many images to look at, but still you get through the whole thorax. And I think the likelihood you miss pulmonary nodules is pretty low. And so this is what we do at the University of Chicago. So here's an example of a regular axial image here on the left. And then here's the MIPT image here on the right. And so what these MIPS are good for in the setting of diffuse nodular lung disease is you see more nodules on one single image and one single plane relative to the underlying pulmonary anatomy. And really that's the name of the game. That's how you subcategorize diffuse nodular lung disease. Before we talk about the subcategories of diffuse nodular lung disease, we really have to talk about the anatomy of the secondary pulmonary lobule. Really, this anatomy is the basis upon the rest of interstitial lung disease is created and built. And so it's important to know this. For diffuse nodular lung disease, I think there's only a few things you really have to memorize. So remember, these are interlobular septa here. So the margins around secondary pulmonary lobules. And within these interlobular septa, as well as the subpleural portion of lung, which is just the edge of a secondary pulmonary lobule. Really, you could think of this as another interlobular septum here. There are lymphatics as demarcated by these green areas, as well as the pulmonary vein shown by the red vessel underneath it. So remember, pulmonary vein, lymphatic, that's really all you have to know in terms of the interlobular septa, as well as the subpleural portion of the lung. Now, in the center of the secondary pulmonary lobule, you have your centrilobular core structure. So here you're going to have your small airways. And so note that there are also some green areas in here as well. So there's lymphatics here as well. But bottom line, the most important structures are going to be your small airways, as well as your small branches of pulmonary arteries or arterioles. And then you also have your bronchial arteries there, though in the setting of diffuse nodular lung disease, the bronchial arteries don't play as big of a role. Okay, so that's really all you have to remember. Interlobular septa, pulmonary vein, lymphatics, centrilobular core structure, you have your airway, you have your pulmonary artery or arteriole, and then you have some lymphatics associated with it. And then if you look more centrally in the axial core structure here, you see obviously vessels, various vessels coming together, and obviously lymphatics and the airway. So now let's talk about the subcategories of diffuse nodular lung disease. So we have random, perilymphatic, and centrilobular. And so random really does mean that. It means entropic. So these nodules, they do not respect the underlying pulmonary lobular anatomy. They're just gonna go wherever the heck they want. And so usually that means that these nodules got there hematogenously, and they will involve the subpleural portion of lung because they're just going, pretty much anywhere they want, just in a haphazard manner. And so if you have these hematogenic nodules, these random nodules, your differential diagnosis really is going to be two things. It's either going to be hematogenic spread of infection or hematogenic spread of metastases. So pretty focused differential diagnosis. It's very useful in that setting. Now, if you have perilymphatic nodularity, it really means that the nodules are clustered around the lymphatics, where the lymphatics are. And so where are the lymphatics again? Again, interlobular septa, subpleural portion of lung, center of secondary pulmonary lobules. And then sometimes they'll cluster along the more central bronchovascular tree as well, because again, that's where the lymphatics like to live. If you see perilymphatic nodularity, really the #1 differential diagnosis, and probably 2 and 3, is going to be sarcoidosis. Certainly you could get other things as well, like lymphangitic carcinomatosis, but really I'm going to, I'm sure at this point you guys have seen cases of lymphangitic carcinomatosis. Really the star of the show there is not the nodularity, it's more the septal thickening, and I'll show you an example of that in just 1 second. But again, we include this in the differential diagnosis because in these patients with lymphangitic carcinomatosis, very often you do have a component of nodularity, which certainly is clustered where the lymphatics are. Okay, so perilymphatic nodularity, most of the time sarcoid. And finally, we have centrilobular. And so this literally means in the center of the secondary pulmonary lobule. And so as opposed to random and perilymphatic nodules, which again, the nodules, so in random, they're going to go wherever they want, just in an entropic manner. And perilymphatic, they're going to go where the lymphatics are clustered. Both of these, in both random and perilymphatic nodularity, you're going to have subpleural involvement. In centrilobular nodules, diffuse nodular lung disease, because they involve the center of the secondary pulmonary lobule, by definition, you should get subpleural sparing, or at least relative subpleural sparing. Most of the time, these nodules got their not hematogenously, through the airways. But remember, the pulmonary artery travels with the airways, so every once in a while, you'll have something that got there through the pulmonary arteries, but that's less common. Usually it's going to be airway related. And obviously, if it's airway related, the first things that we think about are like aspiration, pneumonia, possibly hemorrhage as well. All right, so let's talk about random nodules. Again, I already talked about all this. This is entropic. So this is a drawing. I did make this myself, which is actually kind of embarrassing, right? Obviously, I'm not an artist, but I did my best. So what do these nodules look like on this drawing of it's supposed to be the right lung with underlying secondary pulmonary lobules interdispersed in this lung drawing? Again, these nodules, they don't care about the underlying secondary pulmonary lobular anatomy. They're just going to go any which way. And so note there are subpleural nodules, but there are some nodules that are just kind of all over the place. The important thing for me to kind of outline here is the fact that, so these aren't evenly spaced nodules. So some nodules are going to be closer together. Some nodules are going to be further apart, right? Because remember, this is entropic, right? So these are completely random. So there's no order to them. So it doesn't make sense that they would be evenly spaced apart. You know, when people hear random, they think, oh, these nodules are going to be, you know, each like 2 or 3 millimeters apart. That's usually not what you see in random nodules. Some are closer together, some are further apart. That's what true random nodules are. And again, we see the subpleural nodularity as well. So remember, in random nodules, almost always you will see subpleural involvement. And so this is a random pattern. We think hematogenous spread of infection or hematogenous metastases. And so here's the differential diagnosis again. Hematogenous, so miliary pneumonia or hematogenous pneumonia, hematogenous metastases. Other things can mimic it, but from a practical standpoint, well over 95% of the time, you have random nodules, you're going to be dealing with one of these two things. Here's another example on the coronal plane. So this is just regular coronal image, reconstructed 3 millimeters thick. Here's the MIP in the coronal plane. See how many more nodules you see? And it's much easier to see that some of these nodules are closer together, some are further apart, and they really are not respecting the underlying secondary pulmonary lobular anatomy. There is subpleural involvement. This is random. This patient had disseminated histoplasmosis. Another example here. So again, we see these nodules. They look random, but you know, might be hard to figure out what's going on. So what do? We look at the MIP. Again, MIP really should be standard of care. We see more nodules on a single plane, much easier to figure out that some nodules are closer together, some are further apart. Clear subpleural involvement. Lungs all the lungs down here are affected. I will say that these hematogenous infections and metastases, because the lung bases do get more blood than the upper aspect of the lungs, it's not uncommon to have more basilar predominance for these random nodules. But every once in a while, you will see either diffuse zonal involvement or sometimes a little bit of upper lung preponderance. But usually these are going to be basilar predominant because the lung bases get more blood than the upper aspect of the lungs. But there's another example of random nodules. This patient had thyroid metastases. Another example, well, same example. Just want to, again, outline how well the MIPS outline the distribution of these nodules. Another example here, this one, we don't have MIPS. So unfortunately, this was done before we were routinely doing MIPS. But again, we see these tiny nodules all throughout the lungs, and maybe it's hard to see. It's not projecting well with the zoom. So let's go ahead and blow it up. So these tiny little nodules, some along the fissures, some here, some there, you know, so there's some pleural involvement as well. Remember, so when we see fissural involvement of nodules, that's really subpleural involvement, because if you were to take out the right upper lobe, then the right lower lobe would just expand. And so then this would become the subpleural portion of the lung. It would just expand and fill this space. And these lobes are separate, right? So fissural nodularity really is subpleural nodularity. That's the way to think of it. And so this patient had disseminated tuberculosis, miliary tuberculosis. And this is one of my favorite cases. This looks probably very much like that case of miliary tuberculosis. And so the most interesting part of this case is actually the story associated with it. So again, we see random nodules all throughout the lungs, but this guy had history of bladder cancer, superficial bladder cancer. And so, you know, immunotherapy is now like really hot in terms of treating cancers, but I'll tell you, we've been using immunotherapy for a while now. It's just that the way that the drug companies were sort of putting together and selling it has changed, and it's obviously become more marketable now for the drug companies to sell it. But in superficial bladder cancers, they've been instilling BCG, so you know the BCG, the atypical mycobacterial species, into the bladder, right, through a Foley catheter, and this incites a localized reaction in the lining of the bladder, and so the body attacks the lining of the bladder, and so that's been an effective treatment for superficial bladder cancers, transitional cancers. And so this guy was getting that treatment. This guy was getting a regular installation of BCG into his bladder. One time when he came in, there was a little bit of a bloody tap. So when they put the Foley in, they got a little blood back, but it seemed to be okay, and they instilled the BCG. He comes back a little while later, shorter breath, to the ED. They get a CT scan, and they see this. beautiful random pattern of nodules. And so this essentially is hematogenous spread of BCG into lungs. Remember, the BCG is an attenuated bacterium, right? So they are actually technically still alive. And so this guy actually got infected iatrogenically. So crazy case, not uncommon. I think that you might see this at your hospital, depending on what the clinical practice is for your urologist and for your oncologist who deal with bladder cancers. All right, so that's random nodules. A lot of examples of random nodules. Now let's talk about perilymphatic nodules. Again, these are nodules which are going to be hugging, clustered along where the lymphatics like to live. And the lymphatics like to live in the interlobular septum, subpleural lung, and along the bronchovascular core and centrilobular portion of the lungs. Here's again an example of these nodules along this drawing. So again, where the lymphatics like to live, subpleural lung, along the interlobular septa, along the bronchovascular core. And here's an example on axial CT. We see these nodules clustered along the interlobular septa, along the subpleural portion of the lung, and along the bronchovascular tree, also along the fissures here. But remember, the fissures really, that's just subpleural involvement. Fissure involvement and subpleural involvement are one and the same. They really are the same thing. I will tell you these perilymphatic nodules, which again, most often present in sarcoidosis, very often have this clustered nature to them, in the sense that some portion of lungs, it's patchy. Some portion of lungs are severely affected, for example, right in here. But then even on the same axial slice, you go more anteriorly, and there's portion of lungs which are almost completely not affected. Why does sarcoid like to do this? I don't know. But sarcoid does like to do this. And because sarcoid explains most cases of perilymphatic nodularity, most cases of perilymphatic nodularity also manifest this finding. All right, so if you have perilymphatic nodular, what's your differential diagnosis? It's almost always going to be sarcoid. Now, if you have a chronic beryllium disease clinic at your hospital, maybe you're going to consider berylliosis as well. And based on imaging, they are very, very similar. So if you do have one of those clinics, fine, put in your differential diagnosis. But for 99% of people on this call and in the US, probably you can just stop with sarcoidosis. In the back of your mind, you do have to think about lymphangitic spread of tumor. Though again, in my opinion, most of those cases are very different. So yeah, this is that case of sarcoidosis I showed before. This is that case example, that image over here in the right lung. But I just show you the rest of the lungs as well. So again, these clustered areas of nodularity along with the lymphatics like to live. And again, a patchiness. So severely affected, not affected at all. Severely affected, not affected at all anteriorly, right? So very interesting. Coronary formation shows that it's a mid-upper lung preponderant, which is very common in the setting of sarcoidosis, as again, most of you guys know. If we showed soft tissue windows, you would have seen that the patient does have symmetric hilar and mediastinal lymphadenopathy with some areas of calcification. Another example of sarcoidosis, these are axial post-gadolinium bibe images here. Place I previously worked, we did some pulmonary imaging with proton MRI because we could, right? And we were trying to save some patients some radiation dose. And so the imaging manifestations are actually pretty obvious, especially in patients who have real interstitial lung disease and nodular lung disease. So maybe hard to say, well, this is perilymphatic and not in distribution, but certainly you can see the nodularity. And on CT, again, we see that these nodules are clustered along where the lymphatics like to live, along interlobular septa, along subpleural portion of lung, along the bronchovascular tree. Actually, we're developing a little bit of mass-like fibrosis, which happens with sarcoidosis. So the granulomas can come together and start to develop these masses, and over time can actually develop areas of focal fibrosis as well. And we all know that sarcoidosis is a common cause of upper lung preponderant and central lung preponderant pulmonary fibrosis. So I contrast those two cases of sarcoidosis with perilymphatic nodularity to this case. So this is lymphangitic spread of tumor. So certainly there are some nodules in here, okay? So these yellow arrows here are pointing to some nodules along the interlobular septa. But what is the star of the show here? What is the major finding? It is not nodularity, is it? It's these thick, kind of irregular interlobular septal thickening. And so this is really, to me, what lymphangitic carcinomatosis looks like. It's the septal thickening, which can sometimes be a little irregular or a little nodular. The star of the show, the diva, so to speak, is not the perilymphatic nodularity, okay? But you do have that. And so again, in the back of your mind, you want to make sure that when you see perilymphatic nodularity, you're not missing a case of lymphangitic carcinomatosis. And this is especially important if you already know the patient has a history of malignancy, especially adenocarcinomas, which for some reason like to involve the lymphatics of the lung. All right, so that's perilymphatic nodularity. And now this brings us to centrilobular nodules. And so again, these involve the center of the pulmonary lobules, secondary pulmonary lobules. And so by definition, you should get subpleural sparing. And so with these nodules, because they involve the center of the secondary pulmonary lobules and the secondary pulmonary lobules are relatively evenly spaced relative to adjacent secondary pulmonary lobules, they do have an order to them. If you look very carefully, they do have an order to them. So again, here's an example on my drawing, center of the secondary pulmonary lobule. Here's an example of the subpleural sparing here. So these are ground glass centrilobular pulmonary nodules. And so note that there is at least relative subpleural sparing. You got to ignore this. This is just smudgy ground glass anteriorly in the right lung, so you ignore these areas. But the actual nodularity spares the subpleural portion of the lung, okay? And so note that these nodules, they are, again, more evenly spaced, almost like polka dots on a shirt or on a dress, right? There's an order to them. They're not entropic. So they are very different, in my mind, from the random nodules that we see, which again, some nodules will be closer together, others will be further apart. These are almost all evenly spaced relative to each other. All right, so this is the differential diagnosis for centrilobular nodules, and it's pretty broad actually, and it depends on the temporality of it as well. Given our time constraints, I can't really go into the details of centrilobular nodules, but I'll tell you, this is one of the imaging findings where you kind of have to use a little bit of clinical correlation. So you got to know how the patient presented. You got to know how long the patients have had symptoms. I will tell you in the acute setting, most likely it's going to be aspiration related or pneumonia or perhaps pulmonary hemorrhage, something like that, just because in the acute setting, those are the most common things that we see. But in the subacute setting, other things can cause it as well. So again, we don't have time to go through all these, right? And so, in your own time, Google centrilobular nodules, do some reading on your own. I hope that this will be sort of like the instigator of your interest in diffuse nodular lung disease. I will talk about this though, tree and bud opacities. So tree and bud opacities or tree and bud nodularity is really just a subset of centrilobular nodularity. And in this disease setting or this imaging finding, you can be pretty specific. Well over 95% of the time, if you see tree and bud nodularity, it's going to be due to aspiration or pneumonia or a disease that causes bronchiectasis, like cystic fibrosis. Every once in a while, again, because the pulmonary arteries travel to airways, you can get a tree and bud nodularity or a tree and bud-like pattern from pulmonary arterial involvement, but it's less common. So here's an example of adenovirus pneumonia. So regular axial CT image here on the left. Look at this beautiful subpleural sparing, right? It's like, this is, if you can't see this, right, you should probably choose another field, right? I mean, this is subpleural sparing. Classic, we would put this in a textbook. Again, ignore the smudgy ground glass here in the anterior aspect of the left lung. We MIP it up. And so again, this sort of accentuates the clear subpleural sparing of these tree and bud nodules. Again, ignore that ground glass opacity in the anterior aspect of the lung. Here's a patient with tree and bud nodularity at the lung bases. Let's blow it up here so you can see a little better in the right lung. So these branching areas within the lung bases. And so aspiration can certainly cause this pattern. I think it's probably one of the most common causes of tree and bud nodularity. And so with aspiration, we're looking in the lung bases and most dependent portions of the lungs. Here's a patient with cystic fibrosis. We see upper lung preponderant bronchiectasis with concomitant tree and bud nodularity. So anything that causes bronchiectasis can cause tree and bud nodularity. So bronchiectasis is the finding of large airway disease, inflammatory large airway disease. And so if you have large airway disease, not uncommon to get small airway disease. They're like a gang, they go together. Large airway disease and small airway disease, they travel together. And so when you see these areas of large airway disease that are clearly, obviously involving the upper aspect of the lungs, you should look for manifestations of small airway disease. So things like tree and bud nodularity, air trapping, mosaic attenuation. And so this patient has cystic fibrosis, just for fun. Here's the right lung base blown up. And again, we see these areas of tree and bud nodularity, which are sparing the subpleural portion of the lung. Remember in the upper abdomen, so if you're doing a chest CT, you expect to see fatty replacement of the pancreas. Not always, but this is pretty classic imaging appearance. And then the next organ to go in these patients is usually the liver. So not uncommon to see fatty liver. And as patients get older, you can start seeing some cirrhosis as well. Remember that, again, because the pulmonary artery travels with the airways, sometimes metastases or other things within the pulmonary arteries can give you a tree and bud or branching-like morphology. And so here's a case shared with me by Dr. Abbott from MGH. So we see these areas of distal pulmonary arteries which are enlarged and sort of lumpy bumpy. They're nodular in their morphology. And so this is an example of pulmonary artery metastases, which have this tree and bud-like pattern, but they're a little different, right? They're not as pretty as the airway-related tree and bud nodularity that we see in aspiration or pneumonia. Every once in a while, you'll get these mucinous adenocarcinomas as well, which can travel through the airways, again, because they produce a lot of mucus and they can travel lipidically along the airway architecture. And so oftentimes you get this branching morphology, which has this tree and bud-like feel to them, but again, usually not as pretty as the cases of tree and bud nodularity that you see in the setting of aspiration or pneumonia. And so this case was shared to me by Dr. Godwin from University of Washington. And there's a crazy case. This is a fun case. And so I thought this would be the last case that I show you. So this case was shared to me by Ted Cardoso of Tampa Bay, Florida. And so this guy came in short of breath, young guy, short of breath. And so on CT, you see these fine areas of tree and bud nodularity. Again, note the subpleural sparing. It slaps you in the face, I think, over here in the left lower lobe. Sometimes though, if it's too diffuse, it's kind of hard to figure out if it's tree and bud nodular, if your eyes are tricking you or not. I mean, I think this is pretty obvious here, but let's say, you don't know for sure. Well, then look for an internal frame of reference. So here in the right lung, there's some tree and bud nodularity here, but see more anteriorly, these areas are actually normal lung. There's no branching nodularity in there. So this is your frame of reference. And so these areas are clearly abnormal. So this guy actually was injecting oral tablets. I believe it was like amphetamines, which were supposed to be taken orally. And he was crushing them out, putting it into tap water in a syringe, mixing it up, right, creating a slurry and injecting into his veins. And so this is essentially excipient lung, right? So there's these fillers in oral tablets, things like methylcellulose and talc, which once they get down into the very small arterioles, they get trapped because they're just, they're too big to get through those into the capillary system, and they cause localized granulomatous reaction. So again, if you see diffuse nodular lung disease, you're trying to subcategorize into one of these things: random, perilymphatic, and centrilobular. You see random, hematogenous. Perilymphatic, think sarcoid. Centrilobular, think aspiration, pneumonia, hemorrhage first, and then you got to use a little bit of clinical correlation to figure out what's going on. If you see tree and bud nodularity, you're kind of golden, right? Because most of the time it's going to be aspiration or pneumonia, or perhaps something related to bronchiectasis. But again, in the back of your mind, think to yourself, could it be something vascular as well? Because the airways and the pulmonary arteries travel together. Thank you very much for your attention. I hope you enjoyed my lecture, and I know that you'll like Darel's as well.
Thank you so much, Dr. Chung. Really, really great cases, really, really beautiful illustrations as well. So with that, I'd like to invite Dr. Heitkamp to share his screen and begin his talk.
Excellent talk, Jonathan. That was fabulous. I would like to take just a minute to thank Harp Beatty and the RSNA staff, Amanda Decker and Kara Barker, for making this whole conference series possible. They've organized such an outstanding panel of speakers on a variety of topics, most of which are really bread and butter radiology topics that most residents can benefit from. And honestly, we're all hoping that this model becomes somewhat of a new normal in establishing a standardized curriculum for radiology education. So thank you for you guys for showing us really what's possible. And we all know it's a lot of hard work. So I just wanted to take a minute to let you know we appreciate what you're doing. Okay, so I have nothing to disclose. My topic is on germ cell tumors of the thorax, and to understand the distribution of germ cell tumors in the body, it's really helpful to think about embryology. Primordial germ cells are very interesting in that they form and they differentiate outside of the embryo in the wall of the yolk sac. And this starts happening in about the 3rd week of gestation. These germ cells then have to migrate into the embryo, and they do so along the epithelium and the mesentery of the hindgut. And they continue this migration to what we call the genital ridge. And it's there that they become incorporated into the primary sex cords, which will ultimately become the spermatogonia in men and follicles in the ovaries in women. And this really ends around the 6th week of gestation. So there's multiple weeks of migration of these primordial cells from outside the embryo to the genital ridge. And it's likely errors in this migration that's responsible for the variety of locations that we find germ cell tumors in the adult. One way to think about germ cell tumors really is where they arise in the body, given this embryological migration. Germ cell tumors most frequently arise in the gonads, which should make sense because that's where the vast majority of germ cells are. That's the primary site for migration of these primordial germ cells. Extragonadal germ cell tumors do occur, but they're much more rare. The most common sites for extragonadal origin germ cell tumors are in the midline locations of the body. So the anterior mediastinum, the retroperitoneum, the pineal gland, and the neurohypophysis of the brain, also the sacrococcygeal region of the pelvis. So tissue found in these tumors are histologically identical to gonadal germ cell tumors. So they're thought to arise from this migration error during the journey from the yolk sac to the genital ridge. In terms of overall prevalence, germ cell tumors most frequently occur in the gonads of young adult males. More rarely, they occur in the gonads of females, and finally, most rarely in extragonadal locations of both sexes. Histologically, germ cell tumors are classified into 2 main groups. The most common group are the seminomatous tumors, which are completely undifferentiated germ cells. We call these seminomas in men and dysgerminomas in women. Histologically, these are homogeneous tumors comprised of sheets of uniform cells. About 10% of these tumors express elevated beta HCG, serum tumor markers in the blood. Pure seminomas never secrete alpha fetoprotein, which is another marker that we test for in patients with germ cell tumors. So the presence of any elevated alpha fetoprotein means that we are not dealing with a seminoma. It must be a non-seminomatous tumor. Less common are the non-seminomatous tumors, which all show some degree of differentiation in their tissues. These include tumors that have progressed further with embryonic tissue differentiation, and this would include the embryonal carcinoma and the teratoma, and tumors that have progressed with extra embryonic tissue differentiation. And this would include choriocarcinoma and the yolk sac tumor. This classification into these 2 groups, the seminomatous and non-seminomatous tumors, is very important clinically because compared to the seminomas, the malignant non-seminomatous tumors tend to grow faster. They have an earlier mean age at the time of diagnosis, and they have a lower 5-year survival. The survival rate for seminomas is higher, in part because these tumors are very sensitive to chemotherapy and radiation. The treatment for the non-seminomas is almost always more aggressive and involves the complete surgical removal following neoadjuvant chemotherapy. And this is done to eliminate the risk of malignant degeneration of any residual tumor that's left over, including teratoma. Even benign teratoma has the real risk of degenerating into another tumor type later on. Okay, so one important point, when it comes to malignant germ cell tumors of the chest, The vast majority occur in men. In women, the most extragonadal germ cell tumors occur in the pelvis and in the brain. The most notable exception, certainly to this rule, is benign mediastinal teratomas, which have an equal prevalence in men and women. So going forward in this talk, we're essentially going to be talking about thoracic germ cell tumors in men. Chest CT is crucial for diagnosing, staging, and managing germ cell tumors. If disease is present in the chest, its distribution is usually pretty obvious in allowing us to tell whether it's a mediastinal origin tumor or a testicular origin tumor. And we're going to go over that and show some examples of how you can tell the difference. CT is certainly required for staging, for surgical planning, for disease surveillance, evaluating for recurrence. So really, I would say that it's CT of chest, abdomen, pelvis, and evaluating those serum tumor markers, alpha fetoprotein and beta HCG. Those are the mainstay of diagnosing and managing germ cell tumor, much more so than, say, biopsy. Biopsy in some institutions is rarely performed for diagnosis. Okay, so let's start with a discussion of primary mediastinal germ cell tumors. These arise from the anterior mediastinum almost exclusively, and they usually arise from within the thymus in the anterior mediastinum. They often grow so large that at the time of diagnosis, they extend out of the anterior mediastinum into either the right or the left hemithorax. They can be so large that it's hard to even localize their site of origin. You know, it's hard to even tell where they're coming from. So if you see a giant mass in the anterior chest, you should entertain and try to figure out if it's arising from the anterior mediastinum, because many times that is the case. They are, the primary mediastinal germ cell tumor is the most common extragonadal germ cell tumor. It comprises 50 to 70% of all cases of extragonadal germ cell tumor. And most of these, 60 to 70%, are benign mature teratomas. And again, these occur equally in men and women. Unlike teratomas, malignant mediastinal germ cell tumors are a disease almost exclusively of young men. 40% of these are pure seminomas, and 60% are what we call non-seminomatous germ cell tumors. And they're usually of mixed cell type. Of note, these almost always contain some degree of teratoma elements. Histologically, germ cell tumors of mediastinal origin are identical to those of testicular origin, yet they have a much poorer overall prognosis. Primary mediastinal seminomas are very slow growing, typically large tumors at diagnosis, and they are often completely asymptomatic and incidentally discovered at chest radiograph. They're lobulated. They tend to be quite homogeneous in attenuation on CT, and they don't show a whole lot of necrosis or hemorrhage or cystic degeneration or calcification. So they tend to be fairly homogeneous appearing large tumors. They do metastasize to local lymph nodes and distantly. Treatment has evolved over the years, but generally involves surgery with radiation and cisplatin-based chemotherapy. And this treatment achieves good overall survival. The non-seminomatous germ cell tumors of the mediastinum tend to grow faster, and they look more heterogeneous on chest CT. In general, these affect men that are about a decade younger than the seminomas. There's more cystic change, there's more necrosis and hemorrhage within the tumor itself. There'll be more calcification it'll just look much more heterogeneous on CT. These tumors invade more adjacent structures. So they will invade the pericardium, the heart, the SVC, the lung, and these structures will have to be resected along with the mass, and they're typically reconstructed at the time of surgery. Treatment for non-seminomatous germ cell tumors involves 4 cycles of neoadjuvant cisplatin-based chemotherapy, followed by en-bloc resection of the entire mass and all of the invaded structures. Mature teratoma is a type of non-seminomatous germ cell tumor. It's very slow growing and it's benign. It's comprised of 2 or more embryonic germ cell layers. On CT, it typically appears as a round mass that contains both fluid and soft tissue elements. It almost always contains some degree of fluid. It often contains fat, and it can contain calcium. We often remember that it could contain teeth, so seeing a tooth is almost pathognomonic for a teratoma. I find that to be pretty rare in practice. Treatment for these is surgical resection, and we do that to eliminate any potential for complications, certainly the most dreaded of which is malignant degeneration, and they can degenerate into other germ cell tumors, into sarcomas, into carcinomas. They are sort of, totipotent, so they can degenerate into any kind of tumor. This is a rare case of a non-seminomatous germ cell tumor in a female. This was a female in her 40s. She presented with vague symptoms, and she had elevated AFP and beta HCG. These images were taken after 3 rounds of her chemotherapy, so you can see the tumor already appears quite necrotic. Surgical resection was performed, and they resected the SVC, the pericardium, and the entire right upper lobe. Unfortunately, there was residual yolk sac tumor and choriocarcinoma in the surgical specimen, and this is an independent risk factor for a poor prognosis when there is residual tumor after adjuvant chemotherapy. So this case actually represents only 1 of 3 women out of over 250 primary mediastinal germ cell tumor cases that were treated at my former institution. As a radiologist, it's important to recognize the surgical approaches used for these tumors. And these really depend on the size, the location, and invasion of adjacent structures. The issue is typically how much exposure the surgeon will need during the operation to safely remove the tumor and do the resection of the normal structures. This case demonstrates the median sternotomy approach, and that's used when the tumor is pretty squarely in the midline, when it's just under the sternum, and often when it's not very large, if it's a relatively small mass after chemotherapy. So you can see that this patient was resected through a median sternotomy. You can see the sternotomy wires on the chest radiograph postoperatively, depicted by the blue arrows. So it would be hard to know that this patient had a mediastinal germ cell tumor based on the chest radiograph. The so-called clamshell thoracotomy, that's sort of a colloquial slang term, more kind of appropriately, it's called a bilateral anterior thoracotomy with a transverse sternotomy. Surgeons will refer to it as a clamshell. This is used for very large mediastinal masses that you can see in this case, or when the surgeon needs access to both lungs. If the mass has invaded and grown into both lungs, then they'll need exposure to essentially the whole chest at one time. So this is the most extensive of all the thoracic surgeries that you'll see. You're probably familiar with this, this technique from bilateral lung transplantation. Surgeons often use it. And you can see on the follow-up chest radiograph that there's not a whole lot of hardware left behind after a clamshell. There's a single figure of 8 wire that you can see with the blue arrow. And then there's a pin, a sort of sternotomy pin that is placed across the sternotomy, across the osteotomy, that the pink arrow rather is pointing to. So that's all the patient gets from a clamshell thoracotomy, but it portends that it was a very big surgery and that the surgeon needed access to the entire chest at one time. So it's usually a very large mass. The final approach that's used frequently in mediastinal mass resection is the posterolateral thoracotomy. This is a very commonly used thoracotomy approach in chest surgery. And it's usually employed when there's a small to moderate tumor burden that is primarily in one hemithorax. So you can see this case, this anterior mediastinal mass is mostly in the left hemithorax. So the approach was a left posterolateral thoracotomy. And these patients are left with cerclage wires that stabilize the defect. And you can see those with the pink arrow. Okay, so let's move on to thoracic germ cell tumors of testicular origin. Testicular germ cell tumors are interesting. Testicular non-seminomatous germ cell tumor is the most common solid neoplasm in men under 40 years old. And its incidence has doubled worldwide in the last 40 years for reasons that are not entirely known. Luckily, mortality rates have fallen dramatically with the advent of cisplatin-based chemotherapy. And right now, the overall survival rate, even with metastatic disease, is very good for non-seminomatous germ cell tumor of testicular origin. And it's even better for seminomas. Fortunately, metastatic testicular cancer in the chest is very predictable in terms of its distribution. And radiologists can look for these patterns of distribution and fairly easily distinguish primary mediastinal germ cell tumor from testicular metastatic disease. And the way that I like to talk about metastatic testicular cancer in the thorax is that it obeys the rule of thirds. In a third of cases, these metastases go to the lungs only by hematogenous distribution. In a third of cases, mets go to the mediastinum only, and they follow very closely the lymphatic drainage. And then in a third of cases, mets go to both the lungs and the mediastinum. And so that's very helpful to know sort of where to look in patients with testicular carcinoma. So what's really interesting about germ cell tumor of testicular origin is that the lymph node metastases in the chest show this pattern very similar in the abdomen, which is along the route of lymphatic drainage. So metastatic nodes will ascend from the retroperitoneum and follow this predictable pattern of spread along the distribution of the thoracic duct. And that is this tiny structure that on normal chest CTs is really hard to even notice. In fact, we probably don't even look at it on most chest CTs. It's shown by these pink arrows on these images. On the left, that sort of larger structure is the cysternochyli, which we often see sort of at the thoraco-abdominal junction. The thoracic duct courses up along the esophagus, then crosses the midline to the left near the level of the arch. We can see that in the third image. And then it eventually drains into the left subclavian vein right at the origin of the brachiocephalic vein. So metastases from testicular carcinoma will invade the mediastinum as lymph nodes that target the thoracic duct. So that is sort of what you're looking for and helping to distinguish from primary mediastinal germ cell tumor. And so this is what thoracic lymph node mets look like in testicular cancer. The blue arrows show the retroperitoneal lymphadenopathy, which essentially must be present for disease to rise up into the chest. It's often bulky, like we see here, these bulky lymph nodes that are following the lymph node drainage upward. The pink arrows show adenopathy in the middle mediastinum along the thoracic duct, right up against the thoracic duct. And then the yellow arrow shows adenopathy extending all the way up into the left supraclavicular space where that thoracic duct drains into the subclavian vein. So this pattern is not random. It's very biologic and intentional for this tumor type. Here's another example of thoracic lymph node metastases from testicular cancer. Again, blue arrows showing the retroperitoneal lymphadenopathy. The pink arrows showing adenopathy in the middle mediastinum, right along the thoracic duct. The yellow arrow shows adenopathy extending up into the left supraclavicular space where that thoracic duct drains at the origin of the left brachiocephalic vein. So this is the look of testicular germ cell tumor mets to the mediastinum. So try to burn this image into your brains. Metastatic disease also commonly occurs to the lungs according to the rule of thirds, right? So yellow arrows show randomly distributed lesions suggesting hematogenic spread. The pink arrow, again, shows a lymph node metastasis in the mediastinum along the thoracic duct. Here's another patient showing both lung and mediastinal metastases in essentially the same distribution. So with metastatic testicular cancer, seminomas and non-seminomatous tumors behave in a generally similar way as they did with the primary mediastinal germ cell tumors. The exception is that metastatic seminomas tend to be treated with chemotherapy only, whereas in the germ cell variety, they are resected at surgery. And that the prognosis for non-seminomatous tumors of testicular origin is just much better than mediastinal origin. Okay, so let's quickly review these germ cell tumors of the thorax. Seminomas are large, homogeneous tumors without cystic degeneration, without hemorrhage or necrosis. They have overall a very good survival following surgery and chemoradiation. Non-seminomatous germ cell tumors of the chest are quite heterogeneous on CT with areas of cystic change, necrosis, hemorrhage, calcification, overall just very heterogeneous appearing on CT. They do require surgery after 4 rounds of cisplatin-based chemotherapy. Their overall prognosis is relatively much poorer than their testicular counterparts. Again, the same exact histology under the microscope, but the behavior is much, much different. Teratoma is a round mass, typically contains fluid and soft tissue elements, although it can contain fat and calcification. Its treatment is surgical resection to avoid complications. It can occlude structures, it can erode into structures, and certainly the most durable way to cure a patient and avoid malignant degeneration is to resect these tumors. And then testicular origin germ cell tumors, the anterior mediastinum is a rare location for these to go. You essentially never see these in the anterior mediastinum, and they obey what we call the rule of thirds distribution. So a third of these will be seen as randomly distributed lung metastases, a third as lymph nodes in the middle mediastinum along the thoracic duct, and a third both in the lungs and mediastinum. The lymph node distribution, you really want to see follow the thoracic duct. These patients should have adenopathy within their retroperitoneum. And finally, in terms of management, these patients will always go to surgery if there is substantial residual tumor following chemotherapy. So if these lymph node metastases, and these lung metastases are over a centimeter or so in size, they will go and have these extirpated at surgery to afford a durable long-term cure. Okay, that concludes my talk. Thank you for your attention, and I certainly welcome any questions now or in the future through email.
Thank you so much, Dr. Heitkamp. You know, we do have just a minute here, and there is a question, if you don't mind entertaining it. The question is the thoracic duct considered a middle or posterior mediastinal structure?
That is certainly a middle mediastinal structure. You know, posterior mediastinum you can think of as paravertebral. So along the spine is, at least the way surgeons think of it, as that's being the posterior mediastinum. All of the viscera of the mediastinum, so all of the structures, the esophagus, the heart, the trachea, the thoracic duct, all of those are middle mediastinal structures.
Great. Thank you so much. And we here also very much appreciate your kind words about the series. So I want to thank both speakers again for really a wonderful session, and welcome everybody to join in on Thursday for our next session of the Virtual Noon Conference.